So thank you, everybody. Last talk of the day. I know it's been a great one. I've learned a whole lot just listening to everybody. So I'll try to uh, get to the interesting portions of this talk. We're looking at cranial ultrasound as a POCUS tool going through for older children who have closed fontanelles in our work that we're doing so far on this. This is an emerging area. Don't have any disclosures to talk about today. But this is an emerging area with several gaps, many of which are similar to what we've already heard throughout most of this. And kind of the main highlighted points to talk on are most of the data that we have so far comes from adult studies, and even those are extremely limited when it comes to this type of using ultrasound and B-mode imaging for this type of modality in clinical use. Um, there are also lots of gaps when it comes to the educational aspects of this, and then moving forward, how we continue to study this in a regulated fashion, so that we can gather the data together to come up with more robust scanning protocols in order to detect pathology more accurately. But from what we have so far from a lot of the adult data, which is where the Cupid study means mostly comes from in 2023. Dr. Sarwal's group looked at a meta-analysis of transcranial ultrasonography to detect intracranial pathology, and did a meta-analysis revealing 44 studies in total, and only very few of which, I believe only one or two, actually included pediatric patients in that population. So this is an area where there's lots of room to grow when it comes to cranial ultrasound for intracranial pathology detection for pediatric patients. But the feasibility and exploratory studies that came after the meta-analysis showed reasonable sensitivity and specificity for diagnosing intracerebral hemorrhage in adult populations in the neurocritical care unit when it came to intracerebral hemorrhaging. And from that, a topography was built looking at cranial ultrasound through the transtemporal windows using axial slices, and what would be considered normal anatomy, and then also what certain pathologies like intracerebral, intraventricular, and even subarachnoid hemorrhages and subdurals as well too. But this study was limited in its scanning protocol, and there was a question of whether or not adding different planes like the coronal images and even moving the probe forward to look at the frontal windows, which can be attained just above the eye. Whether or not that would enhance the sensitivity and specificity. And so smaller cohort studies done here recently have actually shown an improved sensitivity when using those. And so those principles have been applied, or we are applying those into the children, which has not been done so far to our knowledge yet. The idea being that in children, it maybe even serves as a better tool, and maybe could be more useful compared to the adult populations, given that the bone windows are typically thinner and you can usually get better windows in kids, especially younger kids. And so that's what we're working on now. So what I'd like to spend the rest of the time doing here, to be mindful of everybody, is just showing you sort of what we're seeing so far and some of the data collection. So this is these images that you're going to see are collected as part of the Cupid Pede study. And I'll go through this more so to show what the normal anatomy look like. And here at the end, I'll show an example of what some of the pathology that we've seen so far, and how you might be identifying this. So when it comes to the scanning protocol that we're using, one of the first things that we're doing, it's about finding the window through the transtemporal window. So what you're seeing here are ultrasound images on the top, and then corresponding CT scans on the bottom of a midbrain view. This is kind of our home base view that we use first, and finding the window starts by identifying the opposite skull, which you can see here on the upper left as a hyperechoic semicircular structure on the contralateral side of the probe. Once we found the window, then the main anatomic structure that you can most easily and readily identify is the midbrain. It's seen by this hypoechoic butterfly, as Dr. Sarwa has coined before. This is a kind of the home base that we like to start in. This gives you a good structure to identify at the midline, to know where you are and orient you inside the brain. And so sometimes it's just, especially when you're new at this and as you're scanning, if you find yourself sliding the probe too far, either cranially or caudally or anterior posterior, getting yourself back at the midline to find the midbrain is a nice home base. So these images are actually from patients, one 4 years old, one 5 years old, and is a great example of the anatomy of not just the midbrain itself, but even some of the brain parenchyma as well that you can see. So some of the anatomic structures that we're regularly identifying in this window, first and foremost, the midbrain and the opposite skull. But then there are some other structures and sometimes artifactual components that are important to recognize as well too. You'll notice this hyperechoic fluffiness around the midbrain, which can be identified on the corresponding CT scan below here as the basal cisterns. And then back here at the back, this you'll see this structure more so in the adults a little bit more readily than some of our younger kids. But this bright hyperechoic dot right at the rostral aspect of the midbrain is the cerebral aqueduct, which is an important structure, especially in identifying regular anatomy. From there, we will sometimes see this is not marked on the slide here, but if I can pull up my laser pointer here. You'll see sometimes behind the midbrain, especially behind the aqueduct, especially as an artifact from the basal cisterns, and this is something to be identified early as a posterior acoustic enhancement, which is this kind of readily seen on this particular image, but in others you will see it. Where the fluid is creating kind of an effective bright structure behind the basal cisterns and the cerebral aqueduct, which could be mistaken for a bleed, but should be recognized as not. From this position, this is going to be a video that I'll show you here of where we're starting from. This is you'll recognize the opposite skull. This is our opposite skull. This is our midbrain here in the middle with our basal cisterns around it. And then from this area, where we're going to go is we're going to pan downwards. Let me take off the laser pointer. We're going to pan downwards and go caudally towards the base of the skull, where we'll start to see, we'll lose some of the echogenic features of the brain parenchyma itself, but what we're going to see here in this area are some brighter linear structures, which are represented by the skull base. So moving forward, these are still images here at the same image here, taken as a still shot from that what we were seeing before. So this here is again a 5-year-old patient with the corresponding CT scan to kind of help us identify the regular anatomy and normal anatomy that we'll see here. So the blue arrows here signifying the area near the clivus, just anterior to the pons, which is going to show up as this bright hyperechoic structure. In many cases, maybe an area where we might see things like bleeds. And is something that's going to be important to identify as you're panning down towards this level. In addition to that, we'll see these two more bright hyperechoic linear structures that are radiating out from the midline there towards the contralateral and ipsilateral sides of the skull. Those, as you're seeing here on the corresponding CT scan, are the petrous portions of the temporal bones, and this is also an important structure because just anterior to that are the sphenoidal wings, where we'll see things like temporal bleeds or subdurals, especially in the adult populations, and we're learning more about that in the pediatric populations as well. Might be a little less common in our particular group. So going from the clivus back up cranially, we'll come across the midbrain, our home point again. But then if you continue more cranially in that position, the next anatomic level that we think is going to be an important part of the regular protocol will be what we're calling the thalamic level. The midbrain will become more anteriorly or superiorly the thalami, which flank this area of the third ventricle bilaterally here. These thalami by the blue arrows here, you're going to see are these hypoechoic structures that just become a little bit larger. And then just in this patient, this is a 6-year-old patient with a great view. Next, of course, right next to the ultrasound here on the left is the CT scan on the right. And we'll see on the ultrasound these two bright hyperechoic linear lines just flanking the midline of the thalami bilaterally. And then in between those two lines is a darker structure, a hypoechoic structure, which correlates to the third ventricle in this patient. And this is something that has been conserved throughout some of our other patients that we've been scanning as well too. More caudally, or sorry, more cranially as we move forward. This is a similar structure and also depends on kind of the orientation that you're holding your probe. Again, like these are axial section cuts. So as we fan a little bit more cranially, we're going to start to identify some other important structures normally should be seen in normal anatomy. Of course, this patient had a normal CT scan. So one of the first ones again to point out, so just to orient again, we're seeing the thalami as these two kind of semicircular hypoechoic structures that are pushing towards the midline there. We could see that on the corresponding CT scan. And then in this next structure here, where I've identified is this hyperechoic, almost Y-shaped structure, which can sometimes look as two dots. So like two dots laterally and then one dot medially. And what we're noticing there is that this is the vascular cord plexus that lies within the lateral ventricles, and is something that is conserved, and we'll see that be contiguous, especially in the scan, which I have an example of here. Here in a second, you'll see that be more contiguous together as you scan up and down. And this is an important structure to identify because this will help see things like hydrocephalus in particular. So this, of course, is the posterior and temporal portions of the lateral horns of the lateral ventricles. Just posterior to that, you'll notice this she-shaped hypoechoic structure just behind the lateral ventricles there of the choroid plexus, which is the splenium of the corpus callosum. And then in this particular patient and in pediatric patients in general, more so than the adults in our experience so far in our population, anteriorly, you see these three lines, and I'm going to back up just to kind of highlight that one more time. These three hyperechoic lines that are surrounding the two the hypoechoic structures, which represent the CSF and the anterior horns of the lateral ventricles. And so this is a great example of how pediatrics in younger children, we're seeing more of the structures a little bit more readily than what has been shown in previous adult studies, which means, or at least to us, that says that there's potential to use cranial POCUS through transtemporal windows in pediatric patients more readily to identify more structures. This is kind of the most vertical portion or most vertex portion of the view is in the cranial in a transtemporal from a transtemporal window in the most cranial view. Um, this is showing you the vertex of the lateral ventricles. So corresponding CT scan here on the right with the ultrasound on the left. Through the transtemporal window, what we notice is again the same sort of features that we've seen in the past. We see the three bright structure lines, which are hypervascular linings of the vascular linings of the lateral ventricles. And what we can see is that they flank, if I can get this going again. There we go. They flank the hypoechoic structures of the bilateral lateral ventricles at the vertex of them of this patient. This will show you more of putting it together, starting at that kind of thalamic level, suprathalamic level. What you can identify in this particular still version is the bright structures here, here, and then here, which show the choroid plexus of the lateral ventricles. You can even make out the hypoechoic C-shaped structure of the splenium of the corpus callosum and then the thalami bilaterally here. That's to orient where we're at right now. And so what we're going to do is we're going to pan cranially and we'll see how they come together and it's more contiguous. And now we're at the vertex where we can see the lateral ventricles at the vertex here in this patient. As part of the study itself, and moving this forward to help with the sensitivity and the specificity, in particular when it comes to identifying lesions versus artifacts, flipping the probe from an axial to a coronal plane has been shown to be beneficial in adults. We're doing the same protocol in kids. The anatomic structures in the coronal plane are a little less identified than what the axial plane has shown us so far because there hasn't been as much done on that in these sections before. However, in kids, I think we're going to find that the anatomy is a little bit more easily identified. So this is taking the same 6-year-old patient. We're flipping the probe coronally. The structures that we've seen in the adults that have been readily identified so that we can identify lesions such as like midline shift have been the falx cerebri, which is the far left arrow, showing us the midline of the brain. And then you'll notice these two hyperechoic lines showing the tentorium cerebelli, which can be helpful as well and something that we should identify. However, in this particular patient and then moving forward in pediatric patients, what we've seen so far is that some of the other anatomy that's more readily identified. So you can see by the yellow arrows here, the two hypoechoic structure finger-like projections here at the midline, which is represented by the midbrain. You can also notice around that midbrain, you'll see the fluffiness of the basal cisterns. And then here at the red arrow, this is something we're working on trying to learn a little bit more and see if we can if this is something that's going to be preserved throughout the rest of the studies. But you'll notice the hyperechoic structure, and I'm sorry, I don't have a scanning image of this one, but you'll in most of these we'll see this be more contiguous, and it's questioned whether or not this might actually be the chord plexus, the lateral ventricle, which it seems like it could be, or it could be gyral patterns, and that's something that more studies need to be done in order to help parse out what the normal anatomy is going to look like from the coronal plane. And the frontal window, a little is an area of future study that I think is going to be really helpful to really identify true pathology versus artifact, and something that we think should be done in these scanning protocols. So this is the frontal window. On the left, we're seeing the axial cut of this with the ultrasound on top, CT on the bottom, and on the right, we're seeing the coronal planes from the frontal windows of the same patient. And what we can identify here is in particular in the axial cut at the midline, and a very important structure when it comes to identifying midline shift and things like traumatic brain injury. We'll notice the falx cerebri here at the midline, but also just posterior to that, what I'd like to point out in this particular patient is we see the frontal horns of the lateral ventricles, and these are very readily seen right here in this patient as well too, in this toddler age child, as well as a lot of the parenchyma as well. And so this is going to be an area I think that will be helpful in not only identifying midline shift, but also confirming if there are other lesions related that we are trying to identify whether or not we think it's artifact. Utilizing your frontal windows is important. Here on the right side of the screen, we're seeing the same thing. So this is a patient with the lateral ventricles, of course, that are readily apparent here. At the midline, you can see the falx line here at the midline, and then you can actually make out the hypoechoic structures of the lateral ventricles right here. This is just a quick example clinically of one of the patients we've collected for study so far of a 4-year-old who awoke with left hemibody weakness out of a nap. He came to our emergency department, was scanned, and found to have an acute thalamic hemorrhage, which we'll show you. This was his ultrasound. So again, we're seeing several different views to kind of show you the importance of collecting the views to in multiple windows to confirm lesion versus something like artifact, which is something that as you're doing these frontal and temporal window views to help identify. So on the top line here is the left side, the bottom line is the right side. You can see from in all of these images a preserved hyperechoic, well circumscribed linear, well circumscribed circular structure, which correlates well to this patient's thalamic hemorrhage. This up here on the far right upper corner, this image is of a frontal window where you can make out the horns of the lateral ventricle. This is the midline, and then his hemorrhage sits back in the contralateral thalamus. This is from the temporal window directly across. We can make out the midline of the septum pellucidum near kind of the thalamic level. And the hemorrhage has obscured some of the normal anatomy that we might otherwise see, and it makes it a little bit harder to put this into context with just a still image, but you can make out the circular thalamic hemorrhage here. This is same thing, but done coronally from the temporal window, so we can see this patient's falx cerebri coming down here at the midline, and then on the contralateral side, the bright hyperechoic structure of the thalamic hemorrhage. This is from the right side frontal window, so the angle shows you again the falx and then the frontal horns of the lateral ventricles. But here in the far corner on this phased array probe, we can make out the portion of the thalamic hemorrhage on the ipsilateral side, and then of course on the ipsilateral temporal windows, both axially and coronally, we can make out this same hemorrhage, which helps help us to confirm with the combination of bilateral and then transtemporal and frontal windows that can help confirm that this is in fact a hemorrhage and not artifact. And then this to show you the patient's CT scan so that you can see kind of what this looks like through gold standard imaging. We can see this patient's CT here. Um, So just to kind of make a quick summary for this study, the anatomy moving forward and what we're hoping to achieve is a protocol, a scanning protocol that can be replicated throughout, so that more of this type of study can be done, so we can learn a little bit more about not only the normal anatomy, but what kind of clinical utility this may have, whether this be an emergency room as a scanning type of protocol to help screen patients in for who may need more dedicated imaging like gold standard CT or MRI, or in areas that are resource austere and imaging is not readily available. Compare that to something like in my field in the ICU, if this is something that can be an alternative to neuroimaging in patients that are too unstable to scan, to take to a CT scanner, to take to an MRI, or if this could be something used as a regular, much like in the TCDs, as a regular neuromonitoring to follow something anatomically and combine that with things like TCD, like blood flow and more of the physiology that's happening. This can give you an anatomic view of something that might end up having an implication on a child's clinical care, whether that be surgically or medically. The frontal windows and the coronal imaging enhance the sensitivity. We know that from the small amount of adult studies that we have, but this needs to be replicated in pediatrics as it's a large gap right now. And easily this start to finish is as nice as a point of care tool. It will take time to learn how to educate people to do this, but the scanning itself takes 10 to 15 minutes and can be done right there at the bedside compared to sometimes very delayed process of getting gold standard imaging done. And so I think this is a hope. We're hopeful that this may be moving forward as a reasonable tool that could be used at minimum as a scanning protocol technique and to screen patients out for who may need more dedicated imaging. So thank you very much for your time. I appreciate it.